Good afternoon, everybody. Thank you, Dr. Sanders. Well, I apologize in advance. This is the least fun lecture of the day. I know there's like endocrine, it's all supposed to be fun, but this is probably the least fun lecture of the day. I'm going to talk about the treatment of hypercholesterolemia. And we're going to start with some background about high cholesterol and atherosclerosis, go over the recent guidelines and the options of therapy. Now, as you all know, that atherosclerosis, atherosclerotic cardiovascular disease is a major constituent of cardiovascular disease in general, and cardiovascular disease is a major cause of mortality. Now, the key initiating event in atherosclerosis is actually the retention of LDL cholesterol and the other cholesterol-rich apolipoprotein B containing lipoproteins within arterial walls. So it's definitely not surprising to know that there are several placebo-controlled studies that have shown that treatment of high cholesterol results in a decrease in atherosclerotic cardiovascular disease. It's just logical. And these studies have shown that you can decrease the risk of atherosclerotic cardiovascular disease in a fashion which is directly proportional to the absolute decrease in the LDL level. And so, for example, if we look at this meta-analysis, which looked at multiple studies using statin therapies and non-statin therapies, both for primary prevention and secondary prevention, you can see that all of them almost reach the same conclusion, which is a 1 millimole per liter decrease in LDL level results in almost 25 relative risk reduction of coronary vascular disease. Now, these studies also have shown that no matter what modality you use to decrease your LDL cholesterol, what matters is really how low you get your LDL levels. The lower you get your LDL levels, the lower the risk of future cardiovascular disease. So lower is better when you are treating for high LDL cholesterol. Now, these studies actually showed did not specify how low you can go. You can go as low as you want. There's no specific low limit, and there is no J-curve effect with these studies. And they were really very reassuring regarding the clinical safety of very low LDL levels. Now, so with this background in mind, what are really the general principles when you want to treat somebody for hypercholesterolemia? Well, the major thing that we really want to achieve is the maximum reduction in atherosclerotic cardiovascular disease. So you want to decrease cardiovascular events from atherosclerosis. And bearing in mind that the higher the risk, like the baseline risk of your patient when you want to start the treatment, the higher the benefit they will achieve when you lower the LDL cholesterol, meaning the greater the risk, the greater is the benefit with the treatment. Therefore, our duty is to pick up these patients with a very high risk for cardiovascular disease. And just to put this in perspective, I want to go over a couple of examples to show you how this works. So if you have a patient who's 45 years old, who's non-smoker, non-hypertensive, with an LDL cholesterol level of 180 milligram per deciliter, which is around 4.7 millimole per liter, and an HDL of 40, and then you calculate the 10-year estimated risk of cardiovascular disease is going to come up to around 1%. Now, if you put this patient on statins, then you are going to achieve, with what we said, around 25% relative risk reduction in atherosclerotic cardiovascular disease. If you put her on statin, you're going to essentially decrease the risk for her from 1% to maybe 0.8%. Is it really worth putting this patient on statin? That's up to you to think about. Versus another patient who is 60 years old with the same characteristics. She's non-hypertensive, she's not a smoker, with the same LDL level with the 180 milligram per deciliter, same HDL level of 40. However, the age here played a major factor, and then the her risk of 10-year risk of having an atherosclerotic cardiovascular disease comes up to 12%, meaning if you treat this patient and you achieve a 25% reduction, you're going to decrease her risk from 12 to 8, and that's probably really worth getting her on treatment. So as we said, the higher the baseline risk, the higher the benefit with the treatment, and that's what you really need to aim for. So if we know that, it's really logical that the intensity of the LDL lowering should be based on the risk of the patient to get atherosclerosis and cardiac vascular events, regardless of the underlying etiology. And with the paradigm in mind that the lower the LDL is, the better, because the lower you get your LDL, the better you have, the more the absolute reduction in your future cardiovascular disease. So how do you decrease the LDL level? Well, I definitely cannot overstate the importance of what we call the heart-healthy lifestyle across the life course, which means it really needs to start from childhood. And when we talk about lifestyle, here we talk about an integration of diet, weight control, and exercise. Diet, we're saying, like, okay, you need to have your patient on high vegetables, high fruits, legumes, whole grains, healthy sources of protein, low-fat dairy products, low-fat poultry, in addition to avoiding tropical oils, avoiding red meats, avoiding sweets, and sweetened beverages. Now, regarding the calorie intake, it has to be adjusted so the patient definitely does not gain weight. And if the patient is overweight or obese, you need to adjust the calorie intake for the patient to achieve weight loss. Regarding exercise, in general, adults are advised to engage in probably 30 to 40 minutes sessions 3 to 4 times a week of moderate to vigorous intensity exercise. Okay, then we have to go to the major step here, which is the LDL lowering drugs. And as you all know, statins are the cornerstone of therapy. And statins are generally these medications that reduce the synthesis of cholesterol by the liver by competing with the MGO co-reductase enzyme that essentially is controlling the rate-limiting step in the cholesterol synthesis. Now, once you decrease the cholesterol in the liver, you're going to upgrade the LDL receptors, and you will increase the clearance of LDL and all the ApoB 100 lipoproteins from the circulation. Now, statins are actually very good medications, very well tolerated, with few specific side effects that are related to muscles and glucose homeostasis. But one major point probably also you need to pay attention to, that many of the statins are metabolized through the liver, through the P450 cytochrome pathway, and therefore drug-drug interactions with other medications that are metabolized through the same pathway can happen, which put the patient at a higher risk of getting the side effects. Now, statins are typically divided into high intensity, moderate intensity, and low intensity categories, and that's based on what is the expected percentage of LDL reduction that happens with these statins. So if the statin results in more than 50% reduction in LDL, it's a high intensity statin. 30 to 49, it's a moderate intensity statin, and less than 30% reduction is considered a low intensity statin. Now, this can be either because of a different type of a statin or just a different dose of the same statin, and it goes under any of these categories. And in addition to statins, there are non-statin add-on medications, and the ones we're going to talk about here are the ezetimibe, bile acid sequestrants, and PCSK9 inhibitors. Ezetimibe is a medication that inhibits cholesterol absorption from the intestine. It's expected to result in around 15 to 20% reduction in the LDL level. It's also a very well tolerated medication. It has the advantage that you don't really need to do adjustment for patients with moderate to severe renal failure. And it's easily taken, 1 tablet a day, no relation to food, so it's actually a good add-on medication. Another one, which is the bile acid sequestrants, and these are also expected to cause around 18 to 25% reduction in the LDL cholesterol. The good thing about these medications that they are not absorbed from the GI tract, so they're not expected to cause systemic side effects. However, being in the GI tract, you think they're gonna get a lot of GI complaints, bloating, nausea, constipation, and you can kind of decrease these side effects by advising the patient to drink plenty of fluids and gradual increase in the dose. Also, because of the effect on absorption, you need to pay attention to other medications that can be affected. So spacing these medications 4 hours before or 1 hour after a medication that can be affected by this medication is absolutely necessary. And also, these medications can result in an increase in the triglyceride level in the blood. So it's not advised to give them to patients who have a baseline fasting triglyceride levels above 300 milligram per deciliter. As for the PCSK9 inhibitors, and then we have 2 FDA-approved medications here, which are the evolocumab and the alirocumab. And these are monoclonal antibodies that are essentially directed against the PCSK9 protein. This is a protein that is synthesized by the liver, usually attaches to the LDL receptor to enhance its catabolism. So essentially, if you are inhibiting this protein, you're just increasing the lifespan of your LDL receptor, and that's how they work. They are very powerful medication. They cause around 60% reduction of the LDL level and the other lipoproteins, and also very well tolerated. Some side effects, maybe upper respiratory tract infection, some low back pain, some maybe muscle pain. The main drawback is the expense, and that they need to be given as an injection, maybe every 2 weeks or every 4 weeks. They are typically given in a regimen that already includes statin plus minus ezetimibe. However, in patients who are intolerant to statins, they could be considered as first-line therapies. So now we're going to go to the treatment guidelines, and I'm going to concentrate on the most recent guidelines that were published a couple of months ago by the European Society of Cardiology and the European Atherosclerosis Society. And 3 main points actually that stood out of these guidelines are the first one, which is consistent with all this evidence that we just reviewed in the background, that the intensity of the LDL lowering should really be based on the risk of the patient, irrespective of the cause. Regardless of the primary or secondary prevention, what matters really is the risk. Second thing, they adopted relatively aggressive goals compared to any previous guidelines that were there before, especially for the high-risk group. And that's also consistent with the background that we just reviewed, that the lower the LDL is, the better. And also, they emphasize that this older approach that we had in the previous guidelines, which is called like fire and forget, like especially for the primary prevention groups, like you just put the patient on the medication and you tell them just go, that's not acceptable to them, or that's not good enough. You really need to set goals for your patient. You really need to recheck their LDL and try to achieve the goals that you set. And this is like essentially a very simple summary of these guidelines. And you can see, and this is the whole thing. There is no more stratification according to primary or secondary anymore. The only thing that matters is the risk of the patient for future cardiovascular risk. So it's either a very high-risk group, high-risk group, moderate-risk group, or low-risk group with the respective goals of LDL accordingly. And so let's see which patients fit in what group. For the very high-risk group. Now, the very high-risk group, it's definitely the easiest one to figure out. The first category of patients, which are the patients who already have atherosclerosis, or atherosclerotic cardiovascular disease, which are the patients you are intending to do secondary prevention on. And what do we mean when we say a patient with clinical atherosclerosis? We essentially mean any patient with a history of myocardial infarction, angina, TIA, stroke, symptomatic peripheral vascular disease, or somebody who had already undergone revascularization procedure for any of these vascular beds. Also under this category falls patients who actually have an unequivocal documented imaging atherosclerotic cardiovascular disease. And what we mean by that they have, at like significant, more than 50% stenosis of at least 2 coronary arteries seen on coronary angio or CT angio, or a significant carotid plaque seen on carotid ultrasound. Now, so that's the easy group, which is the secondary prevention group, patients who already have atherosclerotic cardiovascular disease, definitely a very high-risk group patient for future cardiovascular events. Now, in this group also fall some patients who qualify for primary prevention, which is actually very interesting. And these you can see what kind of patients will fall under that. Some of them will have underlying pathologies that put them at this very high risk. And look, now we're going to start with diabetes. Patients who have diabetes with target organ damage, meaning neuropathy, nephropathy, or retinopathy, or diabetic patients who have at least 3 other major risk factors for coronary vascular disease, or a diabetic patient who has long duration of diabetes, more than 20 years duration. So all these patients with diabetes will qualify as very high-risk patients for future coronary vascular disease. Also falls under this group patients with severe chronic kidney disease, that is an estimated glomerular filtration rate less than 30. And also here falls the patients with familial hypercholesterolemia with either atherosclerotic cardiovascular disease already, or who have another risk factor for coronary vascular disease. So these are the patients who have underlying pathologies severe enough to make them fall under the very high risk group of future coronary vascular disease. Also here, there is this group of patients where they actually are healthy looking patients, completely asymptomatic, but they are more than 40 years of age, and then you happen to calculate their estimated future risk of cardiovascular events. And so essentially there are multiple systems that are available for you to calculate the 10-year estimated risk for the patient. What they used in these guidelines is called the SCORE system, or like the systematic coronary artery risk score system. And essentially, it estimates the 10-year risk of getting a fatal cardiovascular event. And a score of 10% or more in these guidelines qualify the patient as a very high-risk patient for future coronary vascular disease. Now, some of you might be familiar with the other calculator, which has been used also by the American Heart Association, and that also incorporates, the cholesterol and blood pressure and smoking and gender and diabetes history and all that stuff. And the difference between this calculator and the other one, as we said, estimates the 10-year risk of getting a fatal cardiovascular event. This calculator estimates the 10-year risk of getting any cardiovascular event, be it fatal or non-fatal. You can adjust between the two calculators by a factor of 3 for men and a factor of 4 for women. So you can, if you're still used to this one, you can use this one and adjust it to the other one. So anyway, regardless of whatever, as you can see, so now this the very high-risk group. It doesn't matter. It could be a secondary prevention group. It could be a primary prevention group with underlying pathology, or just an estimated risk score. All of them are clumped together as a very high-risk group patient, and they share one LDL goal, which is an LDL goal of less than 55 milligram per deciliter. That's less than 1.4 millimole per liter. In addition, and at least 50% reduction of LDL cholesterol from baseline. And I want you to pay attention to the and, it's not or. The patient needs to achieve both. They need to have a 50%, at least 50% reduction of LDL, in addition to achieving an LDL goal of less than 55 milligram per deciliter. Now, they went even a little bit further for those patients who have already atherosclerotic cardiovascular disease, but they happen to get a second attack, a second cardiovascular event within 2 years of being treated with maximal dose of statin. For these patients, the goal even goes further lower to 1 milligram, 1 millimole per liter, or less than 40 milligram per deciliter. And you can see how aggressive these goals are. Now, to achieve these goals, typically what you're going to do is you start your patient on the maximally tolerated high-intensity statins. You recheck LDL levels within 4 to 6 weeks. You don't achieve your goal, you add ezetimibe 10 milligram daily. Recheck your LDL level 4 to 6 weeks. You don't get your goal, then you might consider adding your PCSK9 inhibitors to the regimen. As for the high-risk group patients, now we're done with the secondary prevention group, so here everybody will be essentially a primary prevention group. And under this category, the high-risk group falls another group of diabetic patients. These are the diabetic patients who don't have end organ damage and have either at least one other major coronary risk factor, or they have a duration of diabetes which is more than 10 years but less than 20 years. Also falls under this category are the moderately severe chronic kidney disease, which means those with an estimated glomerular filtration rate between 30 to 59. As to the familial hypercholesteremia patients, those who don't have other major risk factors will still be considered as high-risk category. And then here also, those patients who have markedly elevated single risk factor, so those with a high total cholesterol of more than 310 milligram per deciliter, or those with an LDL cholesterol that's more than 190 milligram per deciliter, or those with extremely elevated high blood pressure, more than 180 over 110. All these qualify under the high risk category. And then, other than those with underlying pathologies, there are those, as we said, the healthy-looking ones who are more than 40, and you happen to estimate their 10 years future risk of fatal cardiovascular event, and a score of more than 55, less than 10, will qualify them as high-risk group for cardiovascular event. And these patients, all the high-risk group, will share one goal, which is an LDL level less than 70 milligram per deciliter, which is less than 1.8 millimole per liter, in addition to at least 50% reduction of LDL cholesterol from baseline. The moderate risk group essentially will include all your other diabetic patients who don't have end organ damage, don't have any other risk factors, and have diabetes for less than 10 years. In addition to those healthy-looking ones who have an estimated score of that falls between 1 to 5%. The goal for this moderate risk group is an LDL level of less than 100 milligram per deciliter, which is less than 2.6 millimole per liter. And then the low risk group essentially will be only those ones who are asymptomatic, healthy-looking, no underlying pathologies with an estimated risk score of less than 1%. And for those patients, the LDL goal is less than 116 milligram per deciliter, which is less than 3 millimole per liter. So life is not as easy all the time, and sometimes, especially, for those the healthy-looking patients who are asymptomatic, who are classified under this low to moderate risk groups. And you probably will have sometimes a hard time convincing yourself and or your patient to start treatment. So the decision to start a patient on treatment sometimes is not so easy, and sometimes you need to kind of classify and reclassify and try to just convince yourself and convince your patient for the reason to treat. And that's especially significant for those patients who they are low to moderate risk. You have the goals that are set and you want to achieve them. You tell the patient, okay, go on this lifestyle adjustment thing. They come back, you're not reaching your goals. And then you're stuck where, like, should I start the treatment or not? And there are actually some enhancers or modifiers that will help you make this decision. This will make the treatment decision a little bit easier, maybe kind of strengthen your argument with the patient when you're talking about starting a treatment. These are either clinical, biochemical, or imaging modifiers or enhancers. So for example, if you have a patient who is a low or moderate risk patient, and we're talking about these like healthy looking patients, and then like there are certain clinical factors in the history or on the physical examination that actually put the patient at a higher risk of atherosclerotic cardiovascular disease and strengthen your argument to recommend treatment for the patients. For example, if a history of social deprivation or severe psychosocial stress, patients with obesity, whether it's general or central obesity, patients with chronic immune-mediated inflammatory diseases, patients who have signs suggestive of insulin resistance, like maybe fatty liver, polycystic ovary, patients with obstructive sleep apnea. So essentially, you look for these clinical data that will help you strengthen the argument when you're talking to your patient if you want to start treatment. Other than the clinical data, we can use some imaging modalities also to modify your classification or help you with classification or reclassification. And the main ones we're talking about here are either the ultrasound of femoral carotid arteries or the non-contrast CT scan for coronary artery calcium scoring. Now, these modalities essentially are going to help you look for subclinical evidence of atherosclerotic damage to the arteries. And then if you have that evidence, then you will feel more at ease starting or convincing your patient to get on therapy. So, so looking for the plaque burden on the ultrasound or looking for the calcium score on the CT scan will be extremely useful. And actually, the calcium scoring system of the coronary arteries seems to be the most useful imaging study to help you classify or reclassify your patients. And this is how it could be useful to you. Like if you have a low-risk patient, and then you do a calcium scoring and it's 0, and the patient does not have any of the other clinical enhancers that we just mentioned, then you probably feel good not to put your patient on therapy because you know their long-term risk or 10-year risk of coronary vascular disease is low, and we said the risk essentially defines how much benefit they're going to get with the treatment. So you kind of like, maybe you don't want to start this patient on medicine. However, if you have a patient who has at moderate risk and then they have a score between 1 and 99, you will probably be more inclined to put them on statin therapy. Versus somebody who will get a score which is 100 or more, actually you're probably even going to reclassify them, move them the moderate to the higher risk group with a more intensive LDL goals. So that's how this thing could help you. Now, biochemical markers are actually also going to be helpful in classifying or reclassifying your patients. So we can use the high sensitivity C-reactive protein, LPA level. Now, LPA is a modified form of LDL cholesterol. It's highly atherogenic. What's interesting about the LPA, that the levels of it is genetically determined. So actually it is advised that every patient should have the LPA level measured at least, like measured once in their lifetime. And that's gonna be extremely useful, because if the normal levels are less than 30, if your patient has a level that's more than 50, it puts them at a higher risk of atherosclerosis. If they have a level which is 180 or more, actually they will have a risk that is equivalent to somebody with familial hypercholesterolemia, and you're gonna move your patient up to a higher risk group when you wanna treat them. Other markers that you can use are ApoB. ApoB levels are actually useful, especially in patients who have high triglyceride. If you want to see if that high triglyceride is atherogenic, because typically LDL level is a good surrogate to the whole ApoB containing apolipoproteins. However, there's a 20% chance that this is not the case, where the LDL underestimates this burden if the triglyceride is high in obese patients and diabetic patients, where the ApoB 100 will be useful. And if it's elevated, will also put the patient at higher risk of atherosclerosis. Microalbuminuria, persistently elevated triglycerides are other biomarkers that can help you. Now, in addition to addressing your LDL cholesterol, the patient's LDL cholesterol, you should address all the other atherosclerotic risk factors. We're not going to ignore these. Your patient needs to stop smoking. Blood pressure needs to be controlled, whether you want it less than 140/90, or less than 130/80, depends on your patient's risk. If he's diabetic, hemoglobin A1C less than 7%. Decreasing weight, achieving normal BMI, achieving normal waist circumference. All this stuff is extremely important when you are treating a patient with high cholesterol and addressing all the risk factors for atherosclerosis. So in conclusion, it's important for you to recognize that the higher the risk of the individual, the lower your goal for LDL should be. And that's regardless of this is for primary or secondary prevention. The risk is really what matters. You should start treatment as early as possible, because you want to decrease the time of exposure to this high LDL as much as possible. And you need to be as aggressive as possible. Some people are even calling for LDL elimination. This is how bad they think LDL is. Now, this could be usually achieved by statins plus minus ezetimibe, and in some cases PCSK9 inhibitors.